You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 31st, 2023. This week, diets, coronary artery calcium, statins, basic atherosclerotic knowledge, and AFib ablation. First, I want to say thank you to the cardiovascular fellows at Mayo Clinic for having me come as a visiting speaker. I won't say visiting professor because I am no professor, but thank you times 1,000 for choosing me to come and speak about why I am a medical conservative. Now, you always hear the phrase honored and humbled a lot, but it was a true honor to come to such a famous place and to be around such thoughtful, smart people. Okay, first topic today is diet. A group from Canada, including Gordon Guyette, have published a meta-analysis of trials of patients who are at increased risk of cardiovascular disease, and they compared dietary programs. They looked at good outcomes, major adverse cardiac events, MACE, and mortality. They had about 40 trials, such as trials of Mediterranean diet, low-fat diet, etc. And the top-line results were that they found moderate certainty evidence that programs promoting a Mediterranean low-fat diets reduced all-cause death and MI. They also found that Mediterranean-type diets reduced stroke risk. Now, of note, the effect sizes are small. This is in the range of 1% fewer events over the many years of follow-ups. My comments. Oh boy. I do not understand these efforts. First, there are, as the authors write, numerous limitations in these meta-analyses. Even in a single trial, it is near impossible to isolate the effect of a type of a diet. There are just too many other variables. Then there is the matter of adherence, or the matter of control arms of these studies being so heterogeneous. Of course, I love the randomized controlled trial, but I'm putting my cards down here and saying that outside of, say, a prison setting, it seems pointless to attempt these sorts of things with diets. And even if you did such a study in a totally controlled setting, such as a prison, A, how would you translate that to regular people in the regular real world? And B, do you really think that after you control for smoking and exercise, the effect size between say a Mediterranean diet and a regular low-fat diet would be clinically significant? I don't think it would. And at the risk of sounding overly simplistic, and I know I might be, the best diet for patients are the ones that include the least processed food, ones that don't cause weight gain, and ones that people can maintain over the long run. Now, whether the Mediterranean diet or the low-fat diet or the Ornish diet is marginally better in the long run will remain, I think, an unanswerable question, and one that we should probably not waste time and money on. I mean, so much more important in a country such as the U.S. is how to increase adherence to a diet that does not include food that comes in packages or sugar-sweetened beverages. Now, a second study that also appeared this week bolsters this point, I think. Published in JAMA Network Open, a group of European authors led by Dr. Alicia Thompson from Ireland compared outcomes in people in the UK Biobank who reported eating two types of plant-based diet. Now, maybe you didn't know there were two types of plant-based diet, but yes, there are. There are healthy plant-based diet and the not-so-healthy plant-based diet. And I'll tell you a little story here. When I was bike racing years ago, I had a cycling colleague, and he went to a vegan diet. But he never seemed to ride any better, or he never seemed to get any skinnier. I asked about it, but another friend said, yeah, John, he may not eat meat anymore, but Diet Sunkist and dry box cereal isn't much better. So, to no one's surprise, the researchers who used self-reported plant-based diet ingredients noted that the diets that were characterized by high-quality plant-based foods and lower intake of animal products may be beneficial for health. The take-home, I think, is that just because patients report a plant-based diet does not mean it is a healthy diet. All right, next topic is coronary artery calcium and statins. Circulation Outcomes has published a very nice paper, first author Mark Pletcher, on the use of CAC scores to guide statin therapy. Now, I want to make two comments before we get into the core of this paper. First, clinicians overthink statins, I think. Second, regarding coronary calcium, there's no one misunderstanding in modern medicine that frustrates me more than what I see with CAC scans in my city. And maybe in your city it's different. But here, it's as if no clinician or patient in our community has read anything about CAC scans. I routinely see patients who had CAC scans that are already on statins, or are elderly, or had a heart attack, or a bypass, or stents. I mean, if you do a CAC scan on someone who is post-stent or on statins, you fail Medicine 101. I have patients whose lives are torn up by atrial fibrillation, totally symptomatic, but they're more worried about their asymptomatic CAC score of 60. Now, I'm going to come back to this issue. Most listeners of this podcast probably do understand that proponents of CAC suggest that the scores may help guide intermediate risk people in the choice to take statins. That's it. Most listeners probably get the idea that very, very low risk people need not worry about taking a statin because a 25% reduction of future outcomes of a very low risk is still very low. Conversely, very high risk people, say a greater than 20% 10-year risk, these patients get benefit from statins regardless of anything on a scan. It's those in the middle of this risk that might be swayed by, say, a 0 CAC score or a high CAC score. And that's where this sophisticated modeling study comes in. Now, they tested the cost efficacy of 3 scenarios. First, treat with statins without testing. Second, test and treat with statins based on the coronary calcium, say if it's high. Third, neither test nor treat. And they focused on the typical middle-aged adult, about 55 years old, who has an intermediate risk of 7.5% over 10 years. Okay, now again, another sidebar before I go on. Friends, help me spread the word on this. Before we advise patients on prevention, we should always put their basic numbers in the pooled cohort equation or the ACC risk score equation or some risk score equation and estimate their 10-year risk. It shocks me how many patients who ask me about taking statins have no idea what their 10-year risk is. In fact, most patients who ask my advice on statins have no idea there is a risk estimating equation in the first place. If you are in primary care and you're listening to this podcast, please show your patients how to know their 10-year risk and spread the word. For example, all they have to do is look it up on their phone and they can get it in a matter of seconds. All right, back to the modeling study. The authors assume a cost of about $225 for the CAC scan. They also consider low versus higher cost statins, as well as the long-term cost of the cardiovascular events that are going to be prevented by these strategies. And over a lifetime, they project that if statin costs are low, a hypothetical 55-year-old woman with high cholesterol would have essentially the same total healthcare cost in all 3 strategies. So the treat all strategy is optimal because it prevents more coronary events at the same overall cost. So the first take home from this modeling paper is that if statins are cheap and have no adverse effects, there is no reason to get an expensive test to decide whether to use them. But as you know, that is not always the easy assumption because statins can have small negative effects on quality of life. And of course, not all statins are the low-cost atorvastatin. In these scenarios, the authors found that the optimal economic strategy is to test with a coronary calcium scan and then identify and treat the higher risk patients because then only those most likely to benefit would be exposed to the adverse effects and higher statin cost. The take home of this is that when the treatment is more costly, higher cost statins, or less well tolerated, treating to target becomes the best strategy. Now, the model of Pelcher et al. Shows that testing for coronary calcium becomes the optimal strategy if statins reduce the quality of life by as little as 1 to 2%, even when statins are inexpensive. Now, keep in mind that one of the ways that statins can reduce quality of life is simply by having to take a pill every day. The jargon that we use is disutility, but there is disutility in taking a pill every day. The authors concluded that, quote, CAC testing in intermediate risk patients can be cost effective, but only if statins are costly or significantly affect quality of life. So my thoughts on statins and CAC. I think, again, we overthink and misthink statins. In the community, I see people get on primary prevention statins as cholesterol-lowering drugs. Yes, they reduce cholesterol, but that is almost a side effect rather than the effect. The effect is that statins reduce the risk of future cardiovascular events by about 25%. So my idea is to show people their risk off statins and on statins and let them decide if that risk reduction is worth taking the drug, the disutility of taking the drug every day. And in my opinion, CAC does not significantly or reliably modify that risk enough to justify its cost or downstream effects, such as leading to needless testing and treatment like PCI and stents. Now, the one caveat that I've learned lately and that is in my mind is that I think patients need to know this, is that there is likely a cumulative effect of having exposure to statins and lower cholesterol over years, right? And this is where the NNT falls down. When you look at Kaplan-Meier curves of statin trials, even the recent bempedoic acid trial was the same thing. The separation of those curves grows over time. And the treatment trials are short relative to the lifespan of a 55-year-old. I mean, we have trials that go 2 years, 3 years, 5 years at most. The NNT at 5 years may be a lot larger than the NNT at 10 to 20 years. So in other words, the benefit of primary prevention, I think, is on average likely to be a lot greater in younger versus older patients. In fact, the whole point of primary prevention is to become old. So my idea would be to put statins over the counter, put them in an aisle, put a risk calculator in the aisle, have AHA and ACC use some of our professional fees to do this public health campaign to better understand cardiovascular risk and how to lower it with statins. And then let people decide if taking a pill every day is worth the 25% risk reduction that likely gets bigger over time. All right, a related topic is the idea of seeing coronary artery disease on a scan. Now, the Annals of Internal Medicine has published a very nice, unique, novel observational study from Copenhagen. Well, where else but Denmark again? Andrew Fuchs and co-authors set out to define the features of subclinical coronary disease and its future risk. Well, they have something called the CGPS, the Copenhagen General Population Study, and to me it seems like one of the longitudinal studies like NHANES or MESA in which people are followed over time. And for this paper, individuals in the CGPS were offered CTA scans, nearly 10,000 asymptomatic persons over age 40 who did not have CAD had these scans. And get this, crucially, the agreement was that these scans were used only for research. Neither the person scanned nor the doctors who took care of these patients were made aware of their results, and this allowed a very nice natural history experiment. The authors labeled coronary artery disease in two ways according to luminal obstruction, and they made two categories. You either had obstructive or non-obstructive disease, and the other way they labeled it was extent. You either had non-extensive or extensive disease. The primary outcome they looked at was MI. Secondary outcome was the composite of death or MI. They followed these patients for 3.5 years. They were about 60 years old. More than half were women. Now, only 10% of these patients were on statins and even less on aspirin. Again, remember, they were without symptoms nor disease. So these were low-treated patients, so we get really this natural history. And their findings, first of all, subclinical disease was found in 46% of all participants and more frequently in men, obviously. Most common non-obstructive subclinical coronary atherosclerosis was seen in about a third, single vessel obstructive disease less frequent at 8%, and multivessel disease or left main stenosis like terrible disease, only 2%. Now, remember the two binary features I said, obstructive versus non-obstructive and extensive versus non-extensive. For MI, using no disease as the control group, the risk was not elevated with non-obstructive disease, but it was much higher with obstructive disease, 9x higher. The risk of non-extensive coronary artery disease was 2.3 times the control, but for extensive disease, it was 7.6x. And of course, when you combine the two things, right, obstructive disease and extensive disease, non-obstructive and non-extensive, no hazard, but there was a graded increase in risk with positives of either, with the worst being obstructive and extensive disease. And if you had both, your risk of MI was 12x greater over 3.5 years. Now, one finding that they put in the discussion, it's kind of a small finding, but I think it's important, 14 participants of this group with no clinical disease at baseline still had a myocardial infarction over the 3.5 years. So the authors concluded, quote, in asymptomatic persons, subclinical obstructive coronary disease is associated with a more than 8-fold elevated risk for MI. So I'm going to make some comments, both medical and philosophical. Look, I think this is a kind of a remarkable study because of the blinding. Patients with significant disease remained unaware of it, and we get to see the natural history of disease. A provocative feature was that the degree of obstruction was such a great predictor. So was the extent of disease, but again, stenosis, luminal stenosis, seemed to do better. And why is that interesting? Now, the authors summarize this in the paper. They basically write that way back in the beginning, in the 1970s, it became known that high-grade stenoses were high risk, and that's where this whole notion of fixing high-grade stenoses came about. Then, of course, over time, we learned things. We learned courage, buried 2D, ischemia, even the 5-year results of Stitch. It became clear that atherosclerosis looked like more of a systemic disease. And then we all learned that MIs seem to come from less obstructive plaques that are often unseen on angiography. Well, the interesting part of these observations is that the degree of focal stenosis may be as important as we originally thought back in the 1970s. 9 times risk with obstructive disease. So this old saw that obstructive plaques are stable may not exactly be true. Gosh, that would be a big finding. Imagine if yet another belief is discarded in a misinformation pile. The authors cite a study that I had sort of forgotten about. This was the Prospect study, 2011, New England Journal, Greg Stone. I'll link to it. In Prospect, they studied ACS patients who had multivessel disease with ultrasound after the patient had a PCI of the culprit lesion. And what they found in Prospect was that recurrent events were evenly split between culprit versus non-culprit lesions. But non-culprit lesions associated with recurrent events were more likely than those not associated with recurrent events to be high plaque burden, 70% or greater, and have a very small luminal area. In other words, more stenotic lesions seem to do worse. Well, now we sort of have 2 natural history studies that make us rethink this old saw about unstable lesions being non-obstructive. So I'd make 2 conclusions here in one philosophical statement. The first conclusion is akin to the comments the authors made about screening. Now, the great temptation here is to think that we can use CCTA even more than CAC scans to screen. But that is a step that requires randomization, a trial. And there will be one. They cited it in the paper. It's called Danehart trial. That's good. We need to know. The second conclusion is that I sort of eagerly await the author's analysis of plaque burden and the quantifications of the severity of these stenosis. And you know, all of you, that I've been skeptical of many things, but perhaps there will come a day when imaging can enhance prediction, or at least teach us more about this disease, atherosclerosis. Finally, to philosophy and doctoring tomorrow in the clinic. My main points from the previous discussion of CAC and statins remain. Many patients with coronary artery disease did not have events. Some with no coronary artery disease had events. So the imagers posit that imaging will better predict the future and allow us to tailor therapy, but I see it now as far too imperfect, right? There's going to be tons of false positives. Most will be scared for no reason. Some will be relieved and still have an event, and everyone who is imaged falls prey to the risk of downstream testing and interventions. I think it's worth looking at Table 5 in the appendix of this study. And here we get the absolute rates of events, right? The worst risk factor, the obstructive disease, had absolute risks of events of 1 per 100. Now that's off drug therapy. These were mostly non-treated people, 1 per 100. And the combined obstructive and extensive disease, the absolute worst, was only 12 per 1,000 or 1.2 per 100. So again, most people with the worst disease don't have events, even if not treated. So imagine if they were treated, it would be even lower. So my idea for the prevention of heart disease today is for patients, if they are interested in not having heart disease, to live heart healthy as possible, not smoke, put their numbers in the risk calculator. If they like the risk reduction, they can take statins. If they don't, they can keep riding or running or playing golf, and by all means, they need to not ignore symptoms. Because remember, as we get better and better at treating a disease, early detection and screening becomes less important. Okay, last topic today is a quick one. AFib ablation. I'm going to be critical of my field. Again, JAMA has published a very nice randomized controlled trial from researchers based in Ottawa, and it's called the AWARE RCT. The trial might seem specific to us who ablate AFib, but I'm going to bring in larger lessons, so don't tune out. Keep listening. Okay, first you can close your eyes and imagine a standard AFib ablation. Think of the left atrium as the United States map, and the 4 pulmonary veins come in at New England, Florida, San Diego, and Seattle. And what we do using single dots, little RF burns, is we use these dots to create circles or electric fences around the orifices of the PVs, which come in the 4 corners of the atrium. The idea of these circles is that when you put an electric fence around these orifices, you keep the AFib drivers from the pulmonary veins from getting into the left atrium. Yes, I know what you're thinking. You'd think we'd be more advanced, right? We've been doing this for 20 years. But my friends, this is what happens when a procedure gets approved and is well reimbursed. Learning slows down. You can think also of left atrial appendage closure too. Now, recurrences of AFib after these circles are done, called pulmonary vein isolation, occur for 2 reasons. One is the fence that we made with the dots springs a leak. In other words, the veins become reconnected. Or the second problem, a worse problem, is that AFib is being driven by a different geography. Now, in years past, it was almost always leaks in the line that we just simply went in and re-ablated, kind of like a spot weld procedure. But technology has made us a lot better at making these fences, so now when we see recurrent AFib, it most often occurs because we weren't burning in the right geography. The AWARE trial tested the idea of making double circles around the veins. So the idea of double circles around the veins would A, reduce leaks or recurrent PV connection, and B, it might extend the area ablated in the left atrium and maybe by chance alone hit important geographies. Now, to be honest, most of us do a variant of this now, right? We can finish the original circle around the vein so quickly thanks to technology that while we're in the waiting period, it makes sense to just widen a circle and do a little more ablation. It's just tempting. So the trial randomized about 200 patients to a standard single circle PVI or to the augmented double circle. And boom, no difference in freedom from AFib. It didn't matter. No subgroup did better. All right, comments and conclusions. First, you have to say thank you to lead author Dr. Girish Nair and colleagues. This is exactly how we should be doing things in medicine. This is evidence-based knowing, not eminence-based knowing. Things that make sense, like extending circles, making a little bit more lesions, don't always work. And of course, RCTs take work, but randomizing patients is the way we learn what works. The second thing to say is this study can be added to the many studies that show that additional lesions beyond good old standard single PVI does not improve our success rates. Complications were not different in this study, but remember, every additional lesion beyond PVI that does not add to the success rate increases the odds of a complication like perforation or thermal damage to the esophagus. Third comment, many years ago, 2011, when I went to spend a week in Hamburg, Germany, Fifan Ouyang and Dr. Karl-Heinz Cook made the argument that good quality PVI should be the standard. Extra lesions have not been proven to work. Numerous studies have upheld their belief that PVI is what you need to do. STAR AF2 trials showed that in patients with persistent AFib, PVI was the same as all the other techniques with additional lesions. The recent CAPLA, CAPLA study in patients with persistent AFib found that posterior wall isolation plus PVI was no better than PVI alone. And now AWARE, double circles no better than a single PVI circle. Less is more in AF ablation. Finally, it needs to be said that the problem with AF ablation remains a knowledge problem. Since we don't understand the basic causes of AFib, we don't know why PVI works or doesn't work. We cannot even answer the basic question that patients ask, how do you know where to burn? So I think the big breakthrough in AFib will not come from a new energy source like pulse field ablation, but from the basic science labs when we learn more. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a brief review. These little things go a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.